Good afternoon, everyone, and welcome to our series of webinars focused on bringing you information about COVID-19 related topics. The information in these weekly webinars is geared toward long-term care and skilled nursing facilities. We encourage everyone who is interested to attend. My name is Kathy Caudill. I'm a communications specialist with Quality Insights. Today, we will be discussing non-pharmacological pain management. Everyone has entered the meeting on mute, but we will have a discussion following the presentation. If you have questions or comments, please submit them using either the chat or the Q&A tool in your Zoom menu. You can also raise your hand to request to be unmuted to ask your question out loud. We invite you to join us every Wednesday at 2 p.m. for more webinars in this series. Next week, we'll be discussing fall reduction in nursing homes. And now I'd like to introduce our guest today, Shirley Sullivan. Shirley has been a nurse for 25 years. For 12 of those years, she has been here at Quality Insights working on quality improvement. She currently works as a quality improvement specialist with our QIN-QIO nursing home project. Shirley, thanks for joining us today.
Thank you, Kathy. Good afternoon, everyone. As Kathy mentioned, I'm going to go over non-pharmacological pain management, which basically means the management of pain without medications. So prior studies estimate that over 40% of long-stay nursing home residents experience persistent pain, with some studies placing this figure much higher. Pain medications have their place and are often needed in the management of pain. However, our elderly population are often on many medications, and each added medication adds risk of unwanted side effects. And pain medications carry their own increased risk of side effects, such as constipation, confusion, along with, in the case of opioids, dependence. So to minimize the risk of side effects, we want to look at other non-pharmacological methods to manage pain. The first step is to get an accurate assessment of the pain, and then with the individual residents' input, along with their care team, create a pain management care plan together. So we'll go back to the basics with what is pain. Pain is described as an unpleasant sensory or emotional experience that can be acute, recurrent, or persistent. With acute pain, it involves abrupt onset or escalation and usually lasts less than 3 months. And for chronic pain, it's persistent or recurrent, lasting over 3 months. Pain is not part of the normal aging process. This is a common misconception for both our residents and staff. And this misconception can lead the residents not getting proper relief for their pain. And the best indicator of pain is the resident's report of pain. But however, we also should recognize that many residents do not or cannot report pain, such as those that are nonverbal or, have dementia. So approximately 80% of residents have some condition that can be associated with pain. Some common causes can be musculoskeletal, like arthritis, neurological conditions like nerve injuries, shingles, Parkinson's disease, or medications like statins that can cause muscle pain. Or they can have an underlying disease like diabetes that cause their own set of pain. They can cause tingling and burning sensations. And pain itself can cause a wide array of adverse effects such as depression and anxiety, decreased mobility and functional impairment, agitation and aggression, sleep disturbance, and weight loss. And then what happens if the resident has unrelieved pain? You may see functional decline, a decline in activities of daily living, such as not wanting to bathe, eat, or walk around. And then their lack of activity can lead to an increased risk of falls as the resident becomes weaker due to lack of movement. The resident can become completely immobile from unrelieved pain, which we know can lead to contractures, skin breakdown, incontinence, and deconditioning, which is not only a functional loss, but is also a loss of mental status. or cognitive decline. And then the overall quality of life of the resident can decline via developing depression and anxiety, sleep disturbance, behavioral problems such as agitation and aggression. So we really want to keep in mind that unrelieved pain can lead to, a huge decline in our residents' overall health and well-being. Now, as I mentioned before, the first step in managing someone's pain is to get an accurate assessment of the resident's pain. And these are some of the times that a new pain assessment is crucial. The resident should be screened on admission and readmission with a change of condition, such as a fall, with each minimum data set, at least quarterly. And if someone is known to have a painful condition, they should be assessed at least on a daily basis. And additionally, before and after administration of any PRN analgesic medication. Now, who was responsible for the pain management of the resident? The answer is everyone. All departments, from the nursing staff, rehabilitative staff, practitioners, dietitians, social workers, pharmacists, administration, the patients, and the responsible parties. As many departments as possible should play their part in helping to come up with a plan for pain management for each resident. Now, there are many assessment tools available to screen for pain. And many of these you guys will recognize. And here are some of the most common tools used for residents to assess for pain. The first three listed here are for those without cognitive decline. It's the numeric rating scale. We know it goes from 0 to 10, with 10 being the worst pain. Or the FACES pain scale revised. It uses FACES. It goes from pain of showing a face with no pain, and then all the way up to a severe pain. And then the verbal descriptor scale, having the resident rate their pain from, just saying verbally, I have no pain, to they're saying, oh, my pain is as bad as it could possibly be. And then for those with cognitive decline, nonverbal, with dementia, you can use the pain ad scale. And this is just an observation tool that the staff can use, where they really observe the resident's breathing, facial expressions, and body language. And you really want to pay particular attention to residents with dementia or nonverbal, as they are thought to often have untreated pain. So once you have assessed the resident for pain, the next crucial step is to create a pain management care plan. You want this care plan to address underlying causes, for example, better control of their diabetes for diabetic neuropathy. You want to develop the treatment plan based on whether pain is episodic, continuous, or both. The treatment plan and interventions should be based on both the resident's needs and goals, and the source, type of pain, and severity. And then the potential for multiple pain sources should also be considered. For example, do they have both knee pain and abdominal pain? Look at both. And a variety of treatments may need to be tried, and it may take many attempts to find the right combination of treatments and interventions that work best for that resident. You want to develop the care plan with specific goals. For instance, maybe it'll say pain will be maintained at a level of 3 or less on the pain scale for over 75% of the time within 2 weeks. You want to know what is an acceptable level of pain for that resident. And then continue to evaluate and reevaluate if the resident's pain level is controlled according to the plan, and revise it as needed. Now, non-pharmacological interventions, and as a reminder, these are interventions not involving meds. These interventions can be combined with medications and may allow for lower potency or dosing of the pain medication. Research has shown that non-pharmacological treatment for pain can be very effective and can at times work so well that a pain medication may not be needed at all. And when deciding which non-pharmacological approaches to implement, take into account the source of the individual patient's pain and what their preferences are. Now, one of the types of non-pharmacological interventions include those based on the resident's environment. Now, this is not a comprehensive list, but for some ideas, you can, for instance, adjust the lighting, which we know with those with headaches can sometimes help, or just can help with relaxation. You can do something as simple as a warm blanket or adjusting the bed pillows. You can also do activities like crafts, puzzles, books, listening to their favorite music, art, drama, art, therapy can help decrease pain. It can be something as simple as a warm cup of tea for someone who has arthritis, maybe it warms their hands. And of course, encouraging visitors and having someone to speak with. These are all really simple things, but can often make an impact on the resident's experience of their pain. Another category includes physical interventions. You can do PT or OT, positioning using braces, splints, or wedges. You can do normal neurostimulation, acupunctures, transcutaneous electrical nerve stimulation, which is basically a method of pain relief involving the use of a mild electric current that often can be used with low back pain or with diabetic neuropathy. There's massage. The interesting thing about massage is not only does it help with relaxing muscles, but it also helps by interrupting the nerves that report pain in injured tissues. You can do chiropractic treatments, exercise and taking a walk around the building, yoga, warm baths, heat, cold, and compression. There are also behavioral and cognitive interventions. There's meditation techniques and mindfulness-based stress reduction. And with meditation techniques, it really uses neural pathways that make the brain less sensitive to pain and increases the use of the brain's own pain-reducing endorphins. There's progressive muscle relaxation, spiritual counseling, psychological counseling, relaxation techniques, just deep breathing, aromatherapy, biofeedback, where someone basically is taught the awareness of how to control their body and their different muscle groups. And then there's peer support groups. Sometimes just talking with others and, discussing what's going on with your pain can often help. And having input from the care team as well as the resident can really help guide the interventions that you might want to try and which ones are best. Now, each member of the healthcare team should have adequate training on all the interventions used and ensure that the patients and their families receive sufficient education on the selected interventions. It's really important that they understand the intervention and how often it's going to be used. The goal of the patient education should be for the patient to understand the extent of the pain relief expected, how often the treatment should be implemented, and the potential side effects. And providing this education will help to ensure that ongoing treatment will continue and reduce frustration from the potential over-expectation of treatment outcomes. You really want to manage their expectations of what is the pain relief that they can expect from this intervention. Now, I have here a study. It was done by the Agency for Healthcare Research and Quality, and they did a systemic review of all studies related to non-invasive, non-pharmacological treatments for chronic pain and their effects. And this review was conducted through to June of 2022. And we have the link for that study here. And they looked at some of the most common chronic pain conditions and whether there was evidence of improvement of pain for greater than a month after the course of the therapy ended. And they used non-invasive, non-pharmacological treatments. And you can see the conditions listed here along with their corresponding interventions. And they found that these interventions had a positive effects on these conditions. And you can see they looked at low back pain, neck pain, osteoarthritis of knee and hip, fibromyalgia, and tension headache. And I found it interesting for the cognitive behavioral therapy, which is basically therapy that works on change in the automatic negative thoughts someone may have. And that actually helped work with the knee osteoarthritis. I found that interesting. You see exercises listed for many of these. We know just getting it up, moving around, getting our blood flowing often helps with pain. Massage is another common one, and just really relaxation interventions, things to relax people. They've seen that there was definitely improvement with pain that lasted over a month. And when they looked at these interventions, they did not see that there was any harms related to any of these interventions. So in conclusion, non-pharmacological pain interventions, have been shown to help relieve pain, and they work and may decrease the use of pain medications. It is important to do a thorough pain assessment. You want to complete a pain management care plan using a team approach. You want to incorporate non-pharmacological pain interventions. And you may have to try many interventions to find the ones that work best for that individual resident. And you want to educate the residents and the staff on these interventions, the expectations of the treatment, how often they're going to get it, and how it's done. And then you want to have an ongoing evaluation of the resident's pain and revise the care plan as needed. And here are a few resources we have available. One is the Pain Assessment and Advanced Dementia tool, to look at the pain assessment for people with dementia. And then we have the long-term stay patients that has questions and tips to manage pain and reduce opioid use. And then you'll also see here a link that is for all the other resources that we have available from Quality Insights. And now I'll turn it back over to Kathy, and we'll see if we have any questions.
All right, thank you, Shirley. So in a minute, we will begin the Q&A for today's webinar. If you have a question or comment, please submit them using either the chat or the Q&A tool in your Zoom menu. And you can also raise your hand if you would like to ask your question out loud. For anyone wanting a copy of the presentation slides, I'll be emailing them later this week to everyone here today, along with a link to the recording of this webinar. I'd again like to invite everyone to join us for next week's webinar, which will be on reducing falls in nursing homes. And that will be same time, same place next week, Wednesday at 2 p.m. We also invite you to bring your questions to our virtual live chats every Tuesday and Thursday at noon. Deborah Wright will be there to answer your questions on topics like quality improvement initiatives, infection control, or MDS coding. And you can find the links to those live chats in our webinar in the newsletter we send out each Friday called the Last Minute Lowdown. So if you would like to receive that newsletter but don't think you're on our mailing list, you can email me at caudill@qualityinsights.org to get on that list. And I will drop my email in the chat shortly along with Shirley's in case you need to get in touch with her. And it looks like we don't have any questions so far. So I'm going to put those emails in the chat.
Yeah, thank you for dropping the links in the chat.
And I also included the links in the chat for those two resources you showed a moment ago. If anyone has any trouble downloading them, you can contact me to send them to you directly. Sometimes some email services are good at smacking down those emails so that we try to get to send you the resources. Different firewalls. All right, let's see. I don't see any hands up and I don't see anything in the Q&A, so I think we can wrap up here. Before we sign off today, before we sign off, Shirley, I just want to check. Did you have anything else you wanted to add before I close out for today?
No, just thanks everybody for joining and enjoy this beautiful day we have out there.
Yeah. All right, well, that's it then. Before we sign off, I'd like to ask everyone Here to please answer a short evaluation of today's webinar. The evaluation is anonymous and will show as a pop-up as soon as the webinar ends. So if you have a couple minutes to fill that out, we would appreciate it. Shirley, thank you for joining us again today. And we thank all of you for joining us, and we hope to see you back here again next week.
Thank you.